Hello, good morning, good afternoon, and good evening to all the participants. Good morning to our distinguished faculty from the US, and also good afternoon and good evening to all our valued customers as well as our fellow Zimmer Biomet team members. Welcome to yet another webinar session, and it's dubbed hashtag ZBI never stops. I mean, it's meant to say that despite COVID-19 and the situation we're facing now, Zimmer Biomet Institute would like to continue to provide these kind of sessions in order to continue education and continue the interactions between our faculty as well as you, the HCPs. So today we have a webinar on extremities, and it's optimizing shoulder arthroplasty. And we have a host of wonderful faculty whom I will introduce in a little while. Okay. So the next slide actually shows a little bit on sort of a disclaimer, and to also make everyone aware, or participants aware, that not all products are registered in every jurisdiction. So please do check in with your Zimmer Biomet representative should you have any questions about any of the products mentioned here today. Okay. So next, I will actually introduce the panel of wonderful faculty. First, we have Dr. Ashish Babuka. He's from Dinanath Mangeshkar Hospital in Pune, India. Dr. Babuka is a shoulder specialist, and he does joint replacement as well. And he heads the shoulder and sports injuries department at Dinanath Mangeshkar Hospital. He's a very experienced surgeon with 25 years of expertise in the area of reverse, total, and hemi-shoulder arthroplasty. He has many publications to his credit in a variety of peer-reviewed journals, and is a founding president of the Shoulder Society of India from 2011, and has memberships in many other national, regional, and international orthopedic and sports medicine societies. So thank you very much again, Dr. Babuka, and welcome. Next, we have Dr. Bancha. He is from Thammasat University Hospital in Thailand. He got his degree from Sirat Medical School, Mahidol University in Bangkok. Okay, that was in 1995, and he completed his fellowships in sports orthopedics as well as shoulder surgery in Germany in 2003 and 2004, respectively. He is now the Associate Professor of Orthopedic Surgery of the Faculty of Medicine in Thammasat University. He specializes in sports medicine, and in particular the shoulder. He has won the AOS Corporate Advisory Council International Scholarship in 2006 and several awards for his papers and posters, including the Best Innovations Awards, most recently in 2014. He has contributed numerous chapters in several books as well, and has been published in many medical journals, and has presented in numerous national and regional conferences. Thank you very much, Dr. Bancha, and also welcome to you. We have Professor John Sperling. I think he is no stranger to all of you. He hails from Mayo Clinic in the US. Professor Sperling is the Professor of Orthopedics at the Mayo Clinic College of Medicine and a consultant at the Mayo Clinic, Rochester, Minnesota since 2003. He specializes in rotator cuff disease and shoulder arthritis, and involved in the curriculum and course development for advanced in shoulder arthroscopy and elbow surgery. His professional highlights includes recipient of the Walter Reed Distinguished Achievement Award from the University of Virginia School of Medicine, American British Canadian Traveling Fellowships in 2009. He's a fellow of the American Shoulder and Elbow Surgeons Traveling Fellowship in 2007, and he has also received the Charles Neer Award from the American Shoulder and Elbow Surgeons in 2003. He is a member of the Zimmer Biomet development team for the comprehensive shoulder as well as the Alliance glenoid. So welcome, Professor Sperling, and again, thank you for waking up very early and joining and contributing to this webinar. Next, we have someone from Korea who is also no stranger to many of you. Professor Oh Joo-han, he hails from Seoul National University Hospital in Korea. He got his medical degree in Seoul National University College of Medicine in 1992. He's obtained his master's degree in orthopedic surgery in 2001 and his PhD of orthopedic surgery in 2003. He is a tenured professor in the Department of Orthopedic Surgery in SNUH. He specializes in arthroscopy and minimally invasive surgery for rotator cuff tear, labral tears, slap lesion or Bankart lesion in shoulder instability, osteoarthritis, and fractures around the shoulder. He received the Charles Neer Award in 2013 and the NERA Award from ORS in 2016, which is only provided to the best researchers who contributes to the understanding, care, and prevention of injuries to the shoulder and elbow. He's a member also of the Zimmer Biomet development team of the comprehensive mini humeral tray for reverse shoulder. He's published more than 150 papers to date. So, welcome, Professor O, and again, thank you very much for participating this evening and contributing to the webinar. Last but truly not least, we have Professor Thomas DeQuinn. Professor DeQuinn hails from Buffalo University. He is Assistant Professor and Director of Medical Student Education and a staff member of UBMD, Orthopedics and Sports Medicine. He focuses his practice on shoulder and elbow surgery with special expertise in the management of rotator cuff disorders and arthritis of the shoulder and elbow. As Director of the Medical Student Education for the Department of Orthopedic Surgery at the University of Buffalo, he is responsible for overseeing clinical rotations, mentoring medical students, and is also actively involved in resident training and evaluations. Among many other honors, over his career, he has been named a Fellow of the American Academy of Orthopedic Surgeons, received the Casagrande Award, and received the Dr. Benjamin and Lila Obletz Prize for Outstanding Performance in Orthopedic Surgery. Professor DeQuinn, again, thank you very much for contributing to this webinar, and it's also very early for you, so thank you very much. So without further ado, I will hand over to Professor Sperling, who will go through the agenda and start off with some of the questions, poll questions, to get a little bit of the demographics of the attendees. I hope and I wish you a pleasant evening, and I hope this next couple of hours will be very beneficial one for all of you. Thank you very much.
Perfect. Well, thank you so much, Clarence, and thank you very much to the team at ZB to help arrange this webinar. We're very fortunate we have a great group of faculty to discuss with us how we can optimize the results of shoulder arthroplasty for our patients. Now, on the agenda here, you can see we're going to touch on a number of topics, from planning software with Tom DeQuinn, how on an anatomic total shoulder arthroplasty, how do we optimize the exposure and component placement. We're then going to discuss reverse shoulder arthroplasty, how to achieve reproducible results. We'll have time for some question and answer. I'll be talking about new techniques in bone preservation and shoulder arthroplasty. And then Professor O will talk about stemless shoulder arthroplasty. We'd like to make this a very interactive session, so I'd encourage all the folks attending to please type in your questions into the question and answer box. We'll try to answer as many of these as possible during the course of the lectures, as well as during the question and answer. I thought what we would do to get started here is we can ask a poll question. And the question is, are you currently using planning software for your shoulder arthroplasty cases? And if you can please go ahead and answer this question. And then in the meantime, Tom, how about for you in your practice? Tell me a little bit about planning software. Are you using it occasionally, using it all the time? What's happened to you in your practice?
which I'm going to lead it momentarily. But as you know, when I was a fellow with you more than 10 years ago now, which seems like it was just yesterday, we used to plan a lot 2D on CT scans, and I think I would take credit for teaching you how to plan maybe on those cases. But it's been a passion of mine over the years, and I think the advent of the new three-dimensional planning softwares has really been revolutionary in my understanding of glenoid anatomy and my ability to really reproducibly get good results for my patients in both anatomic and reverse arthroplasty. So I use it in all my cases. You know, it's just has become a regular workflow for me, and I think it's been a great addition.
Yeah, Tom, I agree with you. I think the efficiency now with the one planner, that you could plan your cases in an extremely efficient manner. And then when you get to the operating room, there are no surprises. It really helps my intraoperative efficiency that way. But I think what we'll do here is go ahead and we'll see the results. And here are the results. We can see there that the majority of folks currently are not using planning software, about a quarter occasionally, and about 10% on all cases. So I think we're now going to learn quite a bit from my good friend, Tom DeQuinn, about the next generation of case planning with Signature One Planner. Tom.
That's great. Thanks, John. And I guess based on that polling question, I got some work to do. So hopefully at the end of this talk, we can get the 66% who aren't planning on board with maybe doing some planning, and hopefully you end up seeing some benefit from it. But you know, this is the first question that I get, and maybe that's what the 66% are thinking is why bother? You know, why am I going to take the time to go ahead and plan these cases when I can just effectively do the surgery on my own in the operating room without planning? Well, this is my rebuttal to that question. So what you can see here are three clinical pictures at the top from my operating room of different glenoids, and on the bottom, you can see three CT scans that correlate with one of the pictures on the top. And usually I ask people here just to take a minute to look at them and see if they can decide which picture correlates with which CT scan. What you find is it's very difficult to actually be able to see what's going on in the glenoid vault and the scapula with the view that we get in the operating room. What I like to say is we don't get the backstage pass. So you're not going back with the band and hanging out and seeing what's going on. You only get to see what's right in front of your face, which is the glenoid face, which often can be misleading in terms of the actual glenoid bone deformity and the glenoid vault. And that's where planning really comes in and helps you to be more accurate. And we know that version and alignment is important. There's been lots of studies done on this. I'm still a relatively young guy in my career, probably got about another 20 years to practice, and I don't want to be like this guy parachuting into a beach full of crocodiles with holes in my parachute because I put in a bunch of components early in my career that aren't optimized based on their position for biomechanics. Here's an example of one patient that was sent to me from an area physician where unfortunately they left the glenoid retroverted about 27 degrees, and on top of that retroverted the humeral component probably an extra 20 to 30 degrees more than it should. And of course that resulted in a problem, in this case a posterior shoulder dislocation within a year of the surgery. Now, the surgeon liked to blame it on the fact that the patient was shoveling snow here in Buffalo, but unfortunately, the real problem was the result of the bad biomechanics and component malposition. So when we talk about preoperative planning, there's a few different ways to do this. Obviously, plain x-rays are pretty standard, I think, in most people's practices. This is a typical x-ray that you might see here in Buffalo. Unfortunately, a lot of them don't provide a lot of good information about the actual structure and alignment of the glenoid. I think most people have moved on now to the point where they're using advanced imaging software, and for me, that's a CT scan in everybody. But MRIs has also been shown to be equally effective at being able to determine the glenoid anatomy. And what about patient-specific instrumentation? Certainly, this is something, again, that is a tool that can help you to be more accurate. I think we all think that we're really good surgeons and we do a great job for our patients, but ultimately, nobody's perfect. And on occasion, you might have a bad day or you might miss. The repercussions could be dramatic for your patient. So I think utilizing whatever tools you can to make yourself as accurate as possible is really important when we're doing surgical intervention in the form of shoulder arthroplasty. So what are the results of PSI? I think it's been pretty clearly outlined in the literature, both through basic science and clinical papers, that using PSI makes you more accurate. And ultimately, when you look at the studies on this, the amount of glenoid deformity has a role in terms of the amount of benefit. So the more glenoid deformity or the more glenoid wear, the more benefit of getting a PSI guide to make you more accurate in terms of your reconstruction. So let's talk a few minutes now just on the Signature One planning system itself. We'll go over some of the features and benefits. So when Zimmer and Biomet merged, they actually each had their own planning software platform. Zimmer had the PSI shoulder, Biomet had the Signature glenoid. And each of them had some very unique principles that were good and some that maybe weren't so good. And the benefit of what we were able to develop through the combination of the company is a planning software that took the best parts of all of those systems. And you can see the supported implants here now involve the augmented base plate and the TMR plus reverse. So as we were going through the process of redeveloping this software, we really wanted to focus on a few key principles. The first is it has to be simple, it has to be easy to use. So we really focused on that to try and make the tools very interactive, very intuitive, and make the software interface easy for people to use. The second thing was a pure planning option. I think that this became really key as other companies started rolling out this. And historically, in the Zimmer Biomet world, you had to buy the PSI guide in order to use the planning software. That no longer exists. Now we can go ahead and plan every case using the software and then decide if you need a guide or not based on the degree of bone deformity. And that's how I do it in my practice. I think ultimately easy access is really important. So you don't want to be tied to a particular computer for this. You want to be able to access these plans anywhere. And for me in my OR, we have an iPad that we bring into the OR and we're able to look at these cases in real time that we planned out and view the plans and even modify the plan if necessary in the operating room using just an iPad. There's a few features of the guides I think that are also important. We combined the best of the PSI guide and the best of the Signature guide. It's lower profile. It has an excellent fit on the glenoid. And it does allow now with the 2-pin system for depth control, which I think is a huge step forward, especially when we start getting into areas of bone deformity, the alliance and the augmented base plates. This is going to be a key tool that will help you to actually be able to execute the plan. There's a lot of planning software out there that lets you to plan a case, but it doesn't give you any tools necessarily to be able to execute that plan in the operating room. The Signature One system does that for you very nicely. Here you can see the updates to the actual guides. There's additional references for where the pins go to help you with alignment of the actual implants in the operating room. And all these little things help you to be more accurate and help you to place the components where you would like them. And again, you can verify your implant rotation now with the augmented base plate, and you'll see that in the video here momentarily. The biggest turnaround, I think, has been the efficiency. Historically, with Signature, it took 3 weeks sometimes to get what you wanted. Here now, with the pure planning option, in 72 hours, you can have a plan that's ready to go. So if you have a CT scan that's uploaded within 3 days, you can be able to plan that case in the operating room. And the nice part of this is there's actually a human quality check. We didn't dive into this in detail because of the limited time of this presentation, but I think when you're using planning software, what you really want to understand is how the software generates the 3D modeling for your patient. And this is a really critical aspect of it in that many of these involve simply auto-segmentation with computer programs that may have inaccuracies in them. So the benefit of the One Planner system is that there's this human quality check to make sure that the scan meets a particular standard so that you know that you're getting a reproducible scan that matches your patient's anatomy. So again, the pure planning option within 72 hours, we can go ahead and actually plan that case. And for realistically, that 72 hours is behind the scenes. You're not actually waiting for it because the patient goes off and gets a CT scan on their own time, and you just get a notification when it's ready to plan. So short of having a case that is within a day or two of when you first meet the patient or get your CT scan, there's really no delay in being able to plan your cases. So now we'll move on to a video here that is going to roll through a case of my own using the Signature One system and then also the comprehensive augmented base plate. So this is a 70-year-old male. You can see here he's got quite a bit of bone deformity, posterior superior defect associated with rotator cuff arthroplasty. So the first screen gives us a nice preview of what's going on. And then in the planning software, you get the 3 panels. So you can plan in 3D, you can plan both on the coronal axial images. And you can see here we'll be able to activate our components as well as our ream surfaces. There's controls for telling you where the deepest part of the defect is, as well as the amount of medialization of your base plate based on the most lateral aspect. And what we had done there was plan with a mini base plate, and now we're going to back that off until we get to 50% surface ream contact. And we do this because the half wedge augment design of the augmented base plate, we need to ream 50%. And this is how you can plan this effectively and efficiently to give you the best surface contact with the least amount of bone removal. So we've gone to adding in our augments, and you can see here we don't quite have full contact, so we're going to have to go slightly more medial. But what you can see on the plan now, the difference between the mini base plate and the augmented base plate turns out to be 18.5 versus 13 millimeters. So we saved 5.5 millimeters of bone by using an augment on this case. We were also able to plan out the glenosphere as well as the screw length. Here you can see the guide, and what we're going to do, you can see that guide gets an excellent fit on the anterior rim of the bone. We can confirm that that's fully seated, and we're going to put our first pin in. The first pin is the axis pin for the ream, similar to previous signature system. The second pin is going to allow us to do depth control. So once we got our guide on, we can put in the reamer with the depth control guide, which easily kind of snaps right on the shaft of the reamer. And what we're going to go ahead and do now is just ream until that touches the bone. And this is a really important tool because if you remember, I know it was quick in that plan, but we had to ream past 50% in this case because of the amount of bone deformity. So now this allows us to precisely ream the exact amount of bone that we need to take away to allow for full contact of the base plate. So we're not taking away any additional bone. And we can see here now the model confirms the rotation of the augment with the sizing guide. We can go ahead and set our rotation for the augment, which is a great advance using that peg rotation system, which allows us now to precisely prepare the bone and then accurately place our implant exactly in the orientation that the bone was prepared, which is a huge advance of the comprehensive augmented system. We're going to go ahead and now reposition our retractors. This is a key little maneuver for those bad posterior defects. It's what we call the rock-on maneuver. And this really helps you to be able to get the reamer back there to prepare that posterior bone, even in a large defect like this. We'll go ahead now and impact our base plate and go through standard fixation with a 6.5 millimeter central screw and the peripheral locking screws. The nice part about that inserter is that it has that same peg reference system. So throughout the whole process of this case, we're able to control the rotation of the bone preparation and the rotation of the implant insertion. And so that's just a quick summary of how the system works. And hopefully I've convinced you that planning is useful and would be a benefit, especially in your more complex cases. But for me, every case, I find the benefit of being able to plan. And with that, I'll wrap things up and turn it back to you, John.
Tom, thanks so much. That was superb. Great overview of that. And I agree 100%. It's made a dramatic difference in my practice. The number of cases I plan now has gone up almost to uniformity. So really appreciate your insights on that, Tom. Thank you. I think what we'll do now is we'll ask another poll question of the audience. And what is the most challenging part of an anatomic shoulder arthroplasty for you? Humeral exposure, glenoid exposure, soft tissue release, soft tissue balancing, and glenoid deformity. So I'd really like to ask Ashish, my good friend Ashish, a question for him. With anatomic shoulder arthroplasty for you, Ashish, we're going to hear some of your tips coming up here. For you, when you're teaching some residents or fellows, what do you find is the most important step to be able to teach them?
Right. John, thank you. The most important thing is that amongst my students and fellows, I realize there's a lot of apprehension on exposure to glenoid. So today's talk will largely cover the glenoid exposure. But it's an apprehension that is misrepresented because 10 years back, even we carried that apprehension. But a good planning, very similar to Tom's talk, and your instrumentation are the key features to be able to expose the glenoid properly. So we'll touch basics of planning, your approach, and I will give you some tips on the instrumentation as well. For me, I think the most difficult would be probably a medialized glenoid and a deformed glenoid in a short osteoporotic lady are the challenging patient. But more often than not, I have got rid of all my apprehensions now.
Excellent. Well, let's see with the audience here. Interesting results here. We can see that challenging case, that glenoid deformity case, is the one that gives the majority of us the most challenging time. So with that, Ashish, we're very much looking forward to hearing some of your tips and pearls on doing an anatomic total shoulder arthroplasty. And I'll turn it over to you, Ashish.
Thank you, John. Thank you. It's great to be here on the forum with all of you. So this talk was largely predicated on the glenoid exposure because in the 10 minutes that I'm going to cover, we would like to focus on that and not drift to the humerus because that will consume a lot more time. But it's important to understand and simplify the issue here. Most of the time, why is planning required? From my perspective, I think planning is required in order to anticipate challenges. So with experience, you get your comfort level and you spend lesser time on planning. But I would like a lot of the youngsters and fellows to invest a lot of time on planning and anticipate which are the cases that are likely to provide a challenge in advance. A good surgeon, especially in his initial practice, would position the patient himself because you don't want to come up with a problem in between surgery where you find that the arm cannot be extended or it cannot be rotated. And those are simple things that we must never forget. In terms of incisions, sometimes during revision procedures, we realize that the previous surgeon has been flirting too close to the axilla, has taken too small incisions. And so MIS is not for arthroplasty, especially in your initial practice. So it's important that surgeons be bold enough and make a bold incision. Take it much more lateralized. My idea of lateralizing that incision is to move away from the axilla, but also get a nice end-on view of the glenoid. Which are the cases that are likely to be challenging? So the glenoids which have a deformity, the ones that are proximally migrated, the stiff shoulders, revision cases, those are the malunited proximal humerus fractures, and post-trauma cases are almost always the challenging cases. Now, if you don't have specialized instruments, then you should not be doing arthroplasty, and you just need a bare minimum shoulder instrumentation. And for me, the top right, I need a blunt Homan to expose the shoulder joint, and the Fukuda, and especially the wire retractor, is very critical for exposing the glenoid for sure. In terms of approaches, I think all of us are resigned to doing the deltopectoral approach for an anatomic arthroplasty, and that's pretty much a given. But once you start moving into stemless, as Johnny will explain in his talks, then you can go ahead and try the superior approach. But by default, I think most of us are going to use the approach that we are trained in, and that's automatic. But I think we must be familiar with a couple of approaches so that you should know when to use which one. The deltopectoral being the most common, we are exposed and we are used to the deltopectoral more often than not. You can always use a pec major tenotomy, which my professor always told me that you can resect to the top 1 centimeter of the pec major to improve your exposure. I've hardly ever required to do that, exceptionally when I'm doing a lat dorsal transfer, and exceptionally when I'm doing a revision procedure, will I go in to do a pec major transfer as such. So just for completion's sake, the fact that we are aware that there's a deltopectoral approach and there's also an anterolateral superior oblique Mackenzie approach. But when we were trained, we were compulsively asked to do the Nottingham approach for the clavicle osteotomy, which was de jure for shoulder arthroplasty. Looking back, it looks ridiculous that we had to actually go ahead and take a sleeve of the clavicle back and put it back in. And you should just know this for the sake of completion. With the newer instrumentation, I don't even have to think about exposing the clavicle. But MIS is not for shoulder arthroplasty, not for the youngsters. Till such time that you get your comfort level, do not try to make small incisions because that is not what you want to do. When you are planning to anticipate difficult exposures, typically you get these obese patients like beach whales, and you've got short, dwarf patients. Typically, we've operated a couple of achondroplastic patients who have rhizomelic limbs, which are very short, and so they have a short lever arm as well. And if there are multiple scars from the previous trauma, you need to be very careful. As I said, most of us are resigned to doing a deltopectoral approach, and I agree with that. We are familiar with this approach. It's an extensile approach, but we must know the inadequacies of each approach. And if your glenoid exposure is inadequate, then there's a tendency to putting the glenoid into antiversion, and we'll talk about that later in the talk. It is supposedly safer, but there have been axial nerve injuries even with the deltopectoral approach. So don't be under the impression that the superior approach is more harmful to the axillary nerve. Our placement of retractors or retraction of the anterior deltoid and feeling the axillary nerve, sometimes you could do a tuck sign with the axillary nerve to find out where it is. And do protect the anterior deltoid, because wild retraction will affect the anterior deltoid. On the superior McKenzie approach, there's a tendency to putting the glenoid into a superior tilt, although the exposure of the glenoid is supreme and you get an on-face view of the glenoid as such. Now, coming to a little bit of literature, this is an important comparison from George et al. And this was a study they did with almost 43 patients in the lesser tuberosity osteotomy group and subscap peel in the 44 patient group. And they found absolutely no difference in the outcome measures between these patients. So you could choose what you want. But the same group, they went back afterwards, and after 1 year, they found out that the Goodwiller classification had increased in both the groups. It correlated with weakness, and from their perspective, it didn't matter whether you did an osteotomy or whether you did a tenotomy or a peel. My preference, I always prefer to do a lesser tuberosity osteotomy for an anatomical, but I choose to do a peel for doing the stemless nano, or when I'm doing a reverse shoulder arthroplasty. The reason I do a lesser tuberosity osteotomy is I can evaluate my soft tissue balancing ideally perfectly, because then when you bring the fragment in place, you can do a almost hairline reduction and confirm for yourself that it is perfect. This paper from Satish Jandalia has shown that the osteotomy was much better in their hands in the functional art group and in the strength as well. So to each his own, but be familiar and stick to one approach. This, I think, is one of the most important slides for you to understand that you must know where to resect the humerus. When you're dealing with a reverse shoulder replacement, you have the liberty to resect the humerus a little up or a little down, depending whether you're doing an inlay or onlay system. But when it comes to anatomic, you don't want the osteotomy or the resection to extend into the osteophyte. So it's important to remove all the osteophytes and not do the error that you see on the top right figure, where the bottom resection has included the osteophyte, and that would be excessive. So you want to do an anatomic resection for sure, and your adequate resection of humerus will facilitate a good exposure of the glenoid. So a patient like this who has a very medialized glenoid and has a large osteophyte there is going to be challenging for you, and you must understand that you will have to do an appropriate release, including a complete resection of that osteophyte, to be able to expose the glenoid and not make the shoulder tight. The osteophyte, you must remember, is a three-dimensional structure, so you must continue all the way from anterior, inferior, and then go in and resect the inferior capsule along with that osteophyte, but be careful of the axillary nerve that is lurking right below that osteophyte. So this is the superior approach, and you're visualizing the shoulder. And what you see is I've put in my periosteum retractor underneath the pec major to show you the pec major, and then I'm clearing all the soft tissues. I don't remove the pec major as such. The longer biceps is lying right there on the side, and so Once you've exposed this adequately, your placement of retractor should be good enough. What you're showing you there is preparing the latissimus dorsi so you know where that lies, and so that your exposure is adequate. And then you can proceed to doing your lesser tuberosity osteotomy or your subscap peel. And then what you do here on your slide is, you bring that in there. Your positioning of the retractor should be ideal. This is a Y retractor, you can call it the Playboy. And the job of Playboy is to go at 6 o'clock position and retract the entire humerus, which has the stem inside to protect the humerus. And typically, invariably, all the cases I will put one retractor at 2 o'clock, one retractor at 10 o'clock. I retain the long head of biceps till the very end because the long head of biceps is my lighthouse. It tells me where my 12 o'clock position is. And then I start my laborectomy and releases. So I use the long head of biceps till then. Once you've removed it, it's very easy to get confused and distracted. Once you know where you are, then this is the anterior labrum resection along with the anterior inferior capsule and the IGHL. And then similarly, you'll come in posteriorly and do the posterior labrum resection. At the end of this step, you should have a bird's eye view of your entire glenoid. So for the sake of time, we'll move on and get going. And okay. So there you go. So this is again positioning of the retractors in the 10, 2, and 6 o'clock position. That's a very consistent feature for me. And invariably, 3 retractors are all you need to expose the entire glenoid surface. On the deltopectoral approach, there's no need to change the position of the retractors. But it's important that your 6 o'clock Playboy retractor will take the humerus away so that you are in a position to evaluate the entire glenoid. It's very important you should have a complete view of the glenoid before you go in and have a look and start reaming, because if you have an inadequate exposure, this is where you're going to make errors. So once you've exposed the entire glenoid, then the rest of it is a breeze. I will not go through the actual placement of the implant and such things because that will just consume too much time. But I think this step is very important. Once you've seen the center, and when you're placing your implant, it is important to place the implant on the inferior hemisphere of the glenoid, the commonest error. So once you've got your center hole, then you take your reamer. Your reamer should go in easy. And once it goes in easy, you run the reamer as you go in because you can damage. If the reamer takes one of the retractors off, it can fracture the glenoid. It's happened before. So be very careful and ensure for yourself that the reamer is sitting absolutely comfortably on your patient. So moving on, it's important to reiterate that the patient who is stiff in minus 10 degrees external rotation, a revision patient or a post-trauma patient, these are difficult ones. So it's important that you be very careful, spend more time evaluating these patients. Do not hesitate to position a C-arm. I usually position this posteriorly so that it doesn't interfere with my view. I usually use a B-chair position. This is a patient, very stiff patient, young, 58 years old, and I have not hesitated using a C-arm here to evaluate the position of my glenoid and my humerus stem, especially in the lateral position. So I put my C-arm and rotate it into both the 90 degrees views. These are patients with proximal migration, which are difficult. You don't want these patients to come into theater without planning. This is a tuberculosis shoulder. I've done this 14 years back, and you see the glenoid has shifted later on because it's a difficult glenoid which has been infected and it's tilted and still maintained it for 14 years. But these are errors in your practice that you must learn from and ensure that that doesn't happen. Now, one plea from me is if you're doing an anatomical TSA, try and avoid a Regenerex peg and try and prefer a polypeg. This is a senior surgeon who's done this case, and he didn't realize that inadvertently he had put the glenoid in antiversion, and more importantly, his stem was in anteversion rather than retroversion, this patient automatically dislocated, and it's the pain to remove a Regenerex glenoid and revise it into a reverse. Fortunately, being a platform prosthesis, I did not have to remove the humerus on this side. So on the post-op x-rays, evaluate your performance, get your AP and laterals because you would know fresh what is best for the patient. This is a very old patient who's 14 years into her total shoulder replacement. That's a Bigliani flatter shoulder that you're seeing. She came in for a fresh right shoulder rotator cuff tear, but her left shoulder is doing reasonably well, quite happy. So we've had some good results with our anatomicals. There's no need to be disheartened about anatomicals in the young patients and prefer to avoid a reverse shoulder in young patients as such. So finally, in conclusion, I would like to say that it's important for your planning to understand the positioning of the patient. It's important to understand the approach. You must use a commensurate approach that you're used to. Be bold, long incisions. The humeral cut is critical. You must have complete instrumentation for sure. I've not had much time to talk about the releases because of shortage, but planning is very critical to your success. Thank you very much for your patient listening.
Ashish, thank you so much. That really was outstanding. Great to get your tips and pearls on how to perform an anatomic shoulder arthroplasty. I think what we'll do now is we will go ahead and ask another poll question. How often do you use patient-specific instrumentation for your shoulder arthroplasty? And if we can get the audience to do that, I think it'd be great to get Bancha's view on this, who will be coming up next. Bancha, how often in your practice do you use first planning software and then go ahead and get a guide with patient-specific instrumentation, Bancha?
Thank you, John. So I use it for the complicated patients like the revision surgery or the fracture sequelae, right? I didn't use it routinely. But for the patient that I have problem about the anatomy or deformities, I need this patient-specific instrumentations because we have very narrow margin of error, especially our Asian people. We have very small glenoid, so you cannot miss. So PSI, I think that is a solution for me.
Yeah, Bancha, I agree with you. You know, what I've noticed is one of the nice things about the one planner is there's auto segmentation, but it's always checked by an engineer, the quality.
Yeah.
Some of the programs that are out there that are auto segmentation only can be wrong.
Right.
We've shown that almost 50% of the time that can occur. So one of the nice things with the one planner with Zimmer Biomet, you have that quality and assurance. And there are the results. We can see there the majority of people don't use patient-specific instrumentation. Again, I think we'll learn more about this during these talks. And I know I'm excited to hear your talk about reverse shoulder arthroplasty and how to achieve reproducible results.
Thank
Bancha,
you.
please.
Thank you, John. I'm Dr. Bancha Chunchujit from Thammasat University, Thailand. So thank you for the invitation. Today I'm talking about the reverse shoulder arthroplasty, how to achieve the reproducible results. So we need to concern 4 things, right? Number 1 is a patient selection. This is quite important. You need to stick to the indications. Number 2 is a pre-op planning. Okay. Number 3 is you need to know the design, the implant design, and also the surgical techniques. I think number 3 is very important. And then number 4 is post-operative the rehabilitations. So the patient selection, you need to stick to the indications. So now the indication for the reverse is extending more and more, right? Like you have massive irreparable cuff tear arthropathy, 3-4 part fractures, right? And fracture sequelae nowadays is becoming more and more common, especially sometimes in the very young patients. And type 2 B2 glenoid or revision surgery. Okay, so in my practice nowadays, I do more reverse comparing to anatomic shoulder because the indication is extending more and more. And 3 complications that we need to concern. The most common is the scapular notching, instability, and also the infection. So if you stick to these 4 things, you have less complication, right? So the ideal patients for reverse should be number 1 should be old enough, advanced age, irreparable cuff, narrow HI, severe fatty infiltrations, right? Especially the teres minor it's important. You need to look for the teres minor. And last thing is the pseudoparalysis. So these three patients, they have same shoulder weakness, right? But the record is different. The first patient have calf tear problem. The second patient have cervical spine problem. The third patient is the brachial plexus problem. So you need to consider and do not miss. Because if you operate in the patient that have nerve problem, you will have problem, you have complication. So very important, you need to do the clinical assessment, check the posterior deltoid, check teres minor, check cervical spine, and also the brachial plexus, right? So this patient is my fault. This long time ago when I was young, he has a fracture dislocation of the shoulder. So I did the reverse shoulder arthroplasty for him. So X-ray looked nice, but just 1 month later, the patient have dislocation because he has weak deltoid and the patient have a nerve injury. So this I'm very sorry about that. Okay, so you need to stick to the indications. So poor outcome will be in the young patients will have good shoulder function. So try to avoid that in the young patient. But sometimes we cannot avoid, like you have fracture sequelae or revision surgery. And the result of the young patients is not so good comparing to the old because the shoulder score is less comparing to the patient that older than 55. So for the pre-op planning, yeah, this is our like routine X-ray, CT scan, sometimes MRI, right? And sometimes in revision case of fracture sequelae, you need patient-specific instrumentation. In case that you have doubt, you need to check the cervical spine, MRI, or EMG also, right? So do not miss. Like massive cup tear, irreparable cup tear, I need to have X-ray, right? AP, axillary view, and also MRI. Especially you need to look at your teres minor because this is the very important muscles that can make you have abduction, external rotation. So for the cup tear arthropathy, if they have no glenoid problem, I just have X-ray and also MRI. Whenever the patient have the glenoid problem, I will use CT scan also. Also arthritis, yeah, if we, you need all investigation because in osteoarthritis, you need to check the quality of the rotator cuff. Sometimes the patient have the arthritis, primary osteoarthritis, but poor cuff quality. And CT scan will detect the retroversion of the glenoid. So in osteoarthritis, you need 3 investigation. Okay, X-ray, MRI, and CT scan, right? Proximal humerus, most of the time, I just need X-ray and also the CT scan to see the fracture morphologies, right? EMG sometimes is important because in doubt, some patient you cannot, the examination is unclear and the patient have so much pain, you cannot evaluate. EMG is also important. So this is a patient, she's my friend's mother. She has a chronic shoulder pain. So I look at the films. This is like massive, irreparable with arthritic change, right? So I do reverse for her. So after surgery, X-ray look weird, right? So I saw that the patient have this scapula stress fracture, the scapular spine. So I look back at the pre-op. You see that the patient have this stress fracture the scapula. So that's my fault. I didn't see the X-ray properly. So don't forget to look at the X-ray properly. So this patient, I'm very sorry. So 1 year after that, the displacement is more and the clavicle AC joint dislocation because the prosthesis move upward and the patient start to have the notching, right? So I'm very sorry about that. So this is her function. I discussed with my friend, yeah, that her function is not too bad. So I cross follow up her now, right? So next patient is about osteoarthritis. So as I told you, osteoarthritis, when you try to do anatomic shoulder replacement like arches, yeah, you need to make sure that the patient have good bone quality, especially the retroversion of the glenoid should not more than 15 degree, right? And you should have good rotator cuff muscles and function, right? If you have bad bone qualities, like you have retroversion or the poor cuff quality, yeah, better do reverse because it's more but the result is better, okay, comparing to anatomic shoulder replacement. Because if you do anatomic shoulder replacement, you have loosening very fast, right? Because retroversion of the glenoid more than 50 degree. So this article mentioned about the results of the reverse in osteoarthritis. The 2-year follow-up is pretty good, excellent results. So nowadays we have more and more anatomic, we have more and more reverse shoulder arthroplasty in primary osteoarthritis if they have poor cuff quality and severe retroversion of the glenoid. In the rheumatoid arthritis, you have to be very careful because rheumatoid always happen in the young, right? And also the bone is soft, yeah? So like this patient, she's have the rheumatoid arthritis. I do reverse for her. 4 months later, she have motorcycle accident. So you see that there's fracture of the glenoid and also broken of the screw. So I get in, I revise, put the bone graft from the iliac crest, fix her again. So she's happy, but she's active. She ride the motorcycle every day. So 1.5 years later, she's come back with a fracture of the glenoid again. So this is the third operation. So this time, I think we need patient-specific instrumentation because, yeah, this should be the last operation for her. So I did the patient-specific instrumentation and we do the surgery in the sawbone first. We do a 3D printing and do surgery in sawbone. So that's good because you can like rehearsal before you do the real surgery. There will be no surprise in the surgery. And now she's happy, right? So I follow her now 2-3 years. She's doing well, right? And I told her you should stop riding the motorcycle. So patient-specific instrumentation is quite useful, like Tom told you, especially in the patient that complicate, like revision surgery or fracture sequelae. So in the rheumatoid patients, yeah, it's quite challenging because I told you their bone quality is soft. Patient always have poor cuff quality, also poor bone stock, always young patient and still active. So the result of rheumatoid is not so good comparing to the primary osteoarthritis. So for an investigation, the 2D CT scan sometimes is not accurate because the original CT scan were almost never perpendicular to the scapular body. So sometimes you need this 3D CT scan and you will have the better orientations, right? So for the glenoid, I think glenoid is the most critical for the reverse shoulder arthroplasty. Especially our Asian people, our glenoid is very small, right? So you have no margin, you have no room for the error. So like this diagram show you that the posterior glenoid, yeah, there's this danger zone. You can penetrate into the suprascapular notch, right, or spinal glenoid notch. So if you have the patient-specific instrumentation, you can solve this problem, right? So we have the navigation system and patient-specific instrumentation. For me, the navigation system, I don't like it because yeah, it's like real time and it's moving all the time. So for me, I prefer the patient-specific instrumentation. So Valen, can you skip this video? Yeah. So this is the navigation system, right? You see that it's not easy because it keep me moving all the time. So I prefer to use the PSI, okay? So PSI, yeah, you can see that PSI you have less chance of the deviation and the accuracy is very good. It's only 1 to 2 millimeter degree of the deviation, right? So for the surgical techniques, yeah, we use the bead chair position, but very careful when you do bead chair. Some trick is that you need to put the small sandbag in the scapula to push the scapula like protraction. Okay, it's easier for the surgery. So I put this. You see that the small sandbag. So protraction is good. If it's retracted, it's not easy. And semi bead chair position, 45-degree up and very careful. You need to prep and drape the axilla very well because most of the infections coming from the armpit. So use deltopectoral approach. I think this controversy, deltopectoral and the transdeltoid. But for me, I prefer deltopectoral because I can approach to the glenoid better. And from the literatures, they found that you have more notching if you're going from the top, right? You're going from deltopectoral, you have better exposure of the glenoid, but you have higher chance of the instability comparing to the superlateral approach. Okay, so glenoid exposure is the key. I think this is important. Like Achis said, right? You need to have the good exposure, release the tissues. This is my step, right? I release the subscapularis, release humerus, okay? And also I use 135. 135, you have better exposure to the glenoid, right? It's better than 155. And also, you can you have to release the inferior capsule and also the tricep insertions, right? And use the optimal retractor, okay? So for the implant design, right? This is important. You need to know the design of your implant, right? About the glenoid component, yeah, and also the humeral component, right? So how much lateralization for the glenoid? I will not touch this too much because it's a long story. So ideally, I prefer to lateralize about 5 to 10 millimeters, and we prefer the eccentric. Yeah, we go eccentric and inferior overhang about 2 to 4 millimeters. Okay, for the overhanging, and the inferior tilt about 10 to 15 degree. And for the size of the glenosphere, we prefer to use the bigger size, but I think the appropriate size is better. If you use a bigger size, you have the overstuffing and it's difficult for exposure. Okay, larger glenosphere, you have better external rotation and internal rotations, but smaller glenosphere, you have better abduction and also the able abduction external rotations. So this is my preferred techniques for the glenoid exposure. Yeah. So for the online inlay, I think now in the market, like a simple biomet also have the onlay because you can use the seamless system. You have less bone, you remove less bone. For me, I prefer the onlay system. Yeah, and also have more lateralizations and better length of motions. Yeah, comparing to the inlay system, right? But you have higher chance of the acromion stress fracture. For 155, 135, the 135 you have less notching, okay, and also the 155 you have higher chance of notching. So this is a neck sharp angle, that effect, neck sharp angle effect. So 135 you have better exposure, also less contact pressure, and also the better adduction and extension comparing to 155. This is the effect of arm lengthening of the neck sharp angle, right? For the humeral retroversion, this is a study from our friend Dr. Juan O. He found that the individualized the retroversion is better than fixed angle, right? The result is better comparing to the fixed angle. So I follow Juan O. I prefer the individualized retroversion. So I prefer the native retroversion, and also I prefer only system 135. So this is a conclusion of the implant design. For the subscapularis repair is controversy. Subscap repair may better internal rotation, may less external rotation, or improve the stability. So that's controversy. So for the subscap repair or not is quite controversy, and now there's still no conclusion. Some say that you repair the subscap. It's not subscap anymore. It is an adductor because the center of rotation change, right? If you repair the subscap, you have more tension and you have less. If you not repair the subscap, you have less joint reaction force, less deltoid force for abduction. So this group prefer no subscap repair because less joint reaction force and less deltoid force in abduction. Subscap repair may limit external rotation from this article. Okay, and some articles mention that repair or not repair, you have no clinical outcome, no difference in clinical outcome. This paper also a big series. They found that there's no difference in the clinical outcome in repairing subscap or not. This is another article from Juan O. He found that subscap repair. Juan O, you like subscap repair, right? He found that the stability is better in all angles of the motion, right? And this is a conclusion from the subscap, right? Better internal rotation or not is unclear, but you have some limitation external rotation, but you have improved stability after the subscap repair. So this is my approach for the subscap. I prefer subscap repair, but in neutral rotation. If I cannot repair the subscap, is it too much tension? I will not repair it, okay? If I can, I will repair, right? And I do bicep tenodesis to the conjoint tendon like this, and I prefer to use the local antibiotics I use vancomycin powder put into the wound because this is I learned from the spine surgeon. We found that this is quite useful. I have no infection at all after I use this technique. So another scenario is the proximal humerus fracture. This is a 73 years old man. He has 4-part fracture proximal humerus. So we fix his proximal humerus with the reverse, right? So the indications for the repair of the tuberosity. 5 reasons to reattach the tuberosity. Number 1 is to restore the active external rotation. Number 2, to restore the humeral length, that optimal deltoid tension. Number 3, better joint stability. Number 4, reduce the risk of infection because you have better vascularity. And number 5, reduce the probability of the humeral implant loosening, right? So I always repair my tuberosity in 3-4-part fracture. So this is the Pascal-Barlow way to fix the tuberosity. That's a 6 suture technique, and it's worked very well, right? They're like this patient, and the result is pretty good. So it's proof that the reverse, comparing to the hemiarthroplasty, overall result is much better, right? Like this, if you have the hemiarthroplasty, you need to do it, you need the tuberosity healing. But for the reverse, even the tuberosity not healed, the patient still have good function. But if the tuberosity healed, the patient will have excellent function because they will also have a good rotation, right? So this is my article about the teriparatide injection for the reverse patients. You can improve the chance of the tuberosity healing, right? So last scenario, this is the fracture sequelae. Old patients, they have fractures, proximal humerus. My fellow fixed that, is failed. So I revised that for him, yeah, using the patient-specific instrumentation, and the function is pretty good. So lastly, about the post-op rehabilitations, right? So the goal is to pain relief at the first stage. At the first 6 weeks, I treat this patient like massive calf tear. I put the patient in the abduction brace, okay, delay rehabilitation. I start to do rehabilitation after 6 weeks, okay, and after 12 weeks, I do the strengthening exercise, okay, and also don't forget to train the periscapular muscle and also the scapular tilt because that can improve the internal rotation of the patients. So 4 steps to achieve reproducible results. Number 1, patient selection. This is very important. Number 2, pre-op planning. Number 3, surgical techniques and implant design. And number 4, post-op rehabilitation. Thank you.
Thank you, Bancha. That was really outstanding. Thank you so much for that great overview on shoulder arthroplasty and reverse keys to success.
Thank
I think
you,
a brief
John.
question here is really well done for the audience is how do you manage glenoid bone loss? Is it eccentric reaming? Is it bone grafting the glenoid? Is it using an augmented glenoid component? If you can answer. And then I'll be diving into this with my talk. This is an interesting area. There's some new literature that has come out actually addressing this. It'd be great to get everyone's input on how they're currently doing this in their practice. We will go ahead and see here what the results are. And we can see there bone grafting of the glenoid is the most commonly used technique that surgeons use. So we'll be talking a little bit about bone preservation. We know, of course, and we've heard that avoiding superior tilt in reverse arthroplasty is critical. If you have superior tilt, it leads to an increased rate of failure and complications. Here's an example of that on the right. This was a component placed with superior tilt. So we know, of course, that getting neutral inclination or inferior tilt is critical, as well as placing the glenoid base plate on the bottom part of the glenoid. But it's interesting, the glenoid position is different for an anatomic or a reverse. And here's an image of this. The superior tilt from the central aspect of the glenoid is 11 degrees. But when we look from the inferior part of the glenoid, where we place the base plate on reverse arthroplasty, it's actually 21 degrees. So the reverse shoulder arthroplasty angle is 21 degrees of superior inclination from that inferior part of the glenoid. And we know that we have to correct this RSA angle, which ranges from 15 to 25 degrees, to ensure a neutral base plate position. And you essentially have only 3 options to do this. You can eccentrically ream the bone, you can bone graft, or use an augmented base plate, and we'll chat about these options. So there are a number of problems with eccentric ream. You remove a large volume of native bone, you remove the best quality bone, and you medialize the base plate, which could really have a negative effect on your soft tissue tension, and you get shorter screw fixation as well. And another interesting paper came out. If you have 1 millimeter of incremental reaming, you lose 43% of that great cortical bone, what we're looking for fixation. So eccentric reaming has a number of negative aspects. How about bio-RSA? So this has been used by a number of people, but it can be complex and a rate of non-union. There's a paper now on bone grafting with reverse from the Rothman Institute, very experienced surgeons, 25% failure with bone grafting. And there was an historical paper we looked at Mayo Clinic with the number of surgeons, 25% failure rate when you bone graft or revision reverse. So we have moved away from using bone graft for those reasons. And placing a graft is technically challenging. If the graft is too prominent, you can't seat the base plate all the way. And if it's too thin, you don't get contact with the base plate. So here's a prospective study on bio-RSA compared to standard reverse. And what they found is very high rates of notching with bio-RSA, but I think more concerning, in only 2 years, in at least 1/3 of the cases, the bone graft had resorbed away. And you can see why here our hip and knee colleagues have really moved so far away from using bone graft and use metal. And I think that's the future of shoulder arthroplasty as well. This was a great study that was done and spearheaded by Tom DeQuinn and Mike Kovacs at Zimmer Biomet, looking at what is the difference between using an augmented base plate and eccentric reaming. So there were 50 consecutive cases that were planned. The first was using a standard base plate, and then the second was using an augmented base plate along the same axis and looking for bone preservation and lateralization. And I think this slide for me summarizes it very well. We look at an augmented base plate, it preserves 52% of glenoid bone, so huge bone savings, and 4.7 millimeters of lateralization compared to a standard base plate. And you can see that on the image on the bottom there. They also looked at what is the impact if you have malrotation. And if you have 5 degrees of malrotation, you lose 54% of contact. So having an ability to prepare and place the base plate precisely is critical. You can see here the implant on the bottom there, the augmented base plate from Zimmer Biomet is the only one that allows you to prepare it and place it in the identical rotation. So very important. So the benefits of this concept of a bone preserving base plate, augmented base plate, you save greater than 50% bone, longer screws, and you seat it on hard subchondral bone. You get the benefits of lateralization with improved soft tissue tension and decreased risk of notching. So in 2020, a number of thought leaders have come together, Europe, US, Asia, Latin America, using an augmented base plate on all their reverse arthroplasties. And as Tom DeQuinn showed you, once you start planning your cases in one planner, it opens your eyes as to how much bone you're able to preserve using an augmented base plate. And then we adjust the tension on the humeral side. So the benefits of metal, it's simple, it's reproducible, and a very time-efficient method to do it. So here's a case example. Here's a massive cuff tear. We just ream the bottom part of the glenoid to 50%. Then we use the alignment post there. And then we're able to go ahead and place the ream guide on there, which is a nice, secure platform to ream the glenoid. And then we have that ability not only to prepare it precisely, but place the implant precisely. This adds on less than 2 minutes for me compared to my standard reverse and has enormous benefits for the patient. And you can see how the base plate creates some of the tilt, and we get that great benefit again of a central screw fixation where we have a solid construct between the base plate and the scapula. Another huge factor for me is the ability to dial that glenosphere down with the Versatile. I can adjust the soft tissue tension the exact way I want. This for me is a really key feature. And there's the post-operative x-ray showing the bone preservation, which we really like. Here's another example of superior wear using an augmented base plate and then the offset tray, which covers the humerus very nicely, being able to do that. And another case example showing the same construct, which has become my standard construct in reverse arthroplasty. The smaller humeral trays, I think, have been a major advance. They're smaller with less impingement. And having that offset of +3 and +6 really allows me to adjust that soft tissue tension and get greater intraoperative range of motion. And you can see there with the offset tray, you get less impingement between the greater tuberosity and the acromion. So for me, I use a bone-preserving base plate in all my reverses. I use a significant number of small augments. I do use a 40 glenosphere in bigger patients. I only dial the glenosphere down to a few millimeters. We've learned that we don't have to max that out. Just a minimal amount of offset will help you prevent notching that way. And then we use the trays in relation to the greater tuberosity. I use a large number of greater intraoperative motion. On the tray itself, Vitamin E has a great benefit with 9 times less wear in reverse arthroplasty. I thought I'd just touch on now for a couple minutes a really exciting advance. This is the new Alliance glenoid that is just being released now worldwide. When we look at problems with glenoids, we can see here one of the major problems we have is bone loss, which we've discussed today. And when we think about that, the limit of corrective rating really is about 10 degrees of Remy, as you can see there on the bottom. And the augmented base plate, we've learned over time, can really save us bone, particularly a half wedge design, which has the most preservation of any design of an augment. And one of the great things they've done now with ZB is done 5 sizes of glenoid rather than 3. So for an international market, different sizes of patients, this glenoid allows you to match the glenoid to your patient. It also has a consistent splay, so you can change intraoperatively between sizes, which is very, very helpful. And you have options between a a TM post centrally or a poly post, whatever you would prefer. And I think that the engineering team did a great job. They made the central post smaller and the peripheral pegs shorter, so you get less penetration, you remove less bone. So I think the team was very responsive in listening to the surgeons out there, what they want for their patients. And one of the really cool things they have is an off-axis reamer. So you can ream the posterior glenoid from the front. This was a great idea. It really facilitates placing an augmented base plate. One of the other great things, it facilitates revision surgery. So this construct is proven. I just looked up last night the Mayo results. Out of over 600 of these with the original design, we had only 1 loosen out of 600, and that was patient prior surgery. So a great track record of success with this construct going back many years. And the ability to use any size head with any size glenoid is another big advantage. And the size of this augment was based on science. So we looked at 800 of my consecutive patient CT scans that I measured myself, and we looked for what would be the ideal augment. And this was the augment that would be ideal to cover our patients, and that's why it's incorporated in this manner. You can see the flexibility you have to be able to prepare the back of the glenoid from the front. This ball hex rod driver is extremely helpful being able to do that. So I'm a simple person. This is my algorithm now. How do I manage glenoid bone loss? 0 to 9 degrees, I asymmetrically ream. 10 to 24 degrees, I use this augmented component for anatomic. And more than 25 degrees, I use a reverse. So at the end of the day, I want 1 augment thickness for an anatomic right in between that 10 to 25 area, and that 19 degrees gives that to me perfectly. Thanks very much for your time. And I think what we'll do now is we'll transition on and we'll ask the audience here, are you currently using stemless scroll components in your practice? And I think as a lead up to this, my very good friend, Professor O, is going to join us. Professor O, maybe you can comment now on how often you use a stemless implant in your practice now.
Thank you, John. Actually, most of the anatomical TSA, 90% I like to use the stemless humor component. But it's not permitted yet in Korea about the reverse, but mostly I do, especially young people, I like to use the stemless humor component for my routine anatomical TSA.
Yep. Yeah, I agree with you, Junet. I think that's clearly the way the market is going. It's been proven. So I think stemless on anatomic is clearly a great breakthrough. And we'll see the results here from the audience. And again, this is interesting. So some people have used it. I know, Junet, you have enormous experience with stemless. So I can say that we're all very, very excited to hear about your talk, Stemless Shoulder Arthroplasty, State of the Art. Professor O.
Thank you, John. Actually, the history of the stem of the humeral implant, that first generation was monoblock by the near, but recently we have second generation of the modular system with separation of head and stem. But nowadays, recently you can use this. We can control the versions, or we can use even stemless stem. Probably you can. There's several disadvantages of the previous stem prosthesis, kind of the intraoperative fracture, was stress shielding. It's kind of the cause of the proximal humerus, the osteolysis, and also previous prosthesis has another difficulties in case of revision or conversion to the reverse arthroplasty conversions due to the proximal humerus bone destructions. So, this in 2004, there's TEST, the first stemless stem was launched in Europe, and nowadays several companies, most of the companies has their own the design of the stemless stem. As you know, there are several advantages of the stemless stem. As I said before, that we can avoid broaching and rimming of the humeral shaft to prevent intraoperative fractures. Or this is another bone preserving, as you know, it's not only glenoid, but also this is another bone preserving, and also much easier of the revision or conversion to reverse arthroplasty. And also it's really useful in case of proximal humerus malunion or deformities, and also much anatomical, and we can make more the anatomy center rotation in various kinds of shoulder arthroplasties. There are several papers about the restoration of center rotation to real native human anatomy, and there are several papers of comparing of the ability of restoring of native glenohumeral anatomy, measuring this kind of several measurements, humeral lateral offset, neck shaft angles, and so on. That interestingly, there are no difference between stemmed or stemless humeral components, but neck shaft angle is much better in terms of the more anatomical restorations and so on. So let's talk about the stemless stem in anatomical TSA. There are not many clinical outcome papers in the literature. That this is the first paper in 2010 that 72 patients of the stemless anatomical TSA with 2 years follow-up that they say really good outcomes. And also, this is the comparing paper about the first generation and second generation stemless, that you can guess that first generation was the worst outcome. And this Nordic registry says that stem versus stemless, that there are no difference between in terms of the revision. And also, as you see in the right button, upper side of the slide, that's 5-year short-term follow-up was more than 90% of survivor, both of stemmed and stemless implant. And this is another interesting study that's comparing the various stemless implants of the different company. That's in terms of short-term follow-up of the 5 years, there's no difference between implants of the stemless humerus. And this is another interesting study that there's several kinds of the implant geometry, the fixation geometry of the several stemless. This kind of the simulation study says that, sorry for this busy slide, that they concluded that centrally pegged implant produce lowest simulated resorbing potential, whereas those kind of the peripheral implants, like a nanostem of Zimmer Biomet, had the greatest percentage of the implant bone contact area. So every stemless implant has different characteristics, so we have to consider the specific considerations about that choice of the stemless stem. This is the longest follow-up study of the stemless stem, anatomical TSA, for 9 years. That in this study, in the European study, says that only one patient of radiolucency and no revision. So till now, it is good outcomes in terms of the long-term clinical outcomes. This is my patient of 5 years follow-up. Full range of motions and no pains and so on, and no initial loosening or low initial displacement and no radiolucencies of 5 years. So I like this kind of stemless stem. Another advantage bone preserving, as you know, that this is a paper, published paper of the conversion comparing the stemless and stemmed primary implants. That they says that stemless is much better, and this is my case of the anatomical TSA with stemless with convertible glenoid base plate. I have to revise this to conversion to the reverse arthroplasty due to the subscap failure. You will see the video that you can see that conversion from without, oh, where's the video? Would you please show me the videos? Okay, conversion to the reverse, that's not that easy. Sometimes we have to really careful about the pulled out of the remaining nanostem, or we can be careful about the fractures of the metaphysis. It is not that easy that you can imagine, but not that difficult comparing to full conversion of the stemmed prosthesis to the another long stem or short stem prosthesis. That's not that different. They are difficult, I think. But you have to be really gentle to take it out the humeral head and also those kind of the implants separating from the nanostem. You can check that stability of the nanostem that I found it was good. And conversion to the glenosphere, that's much easier than humerus. It's really easy to take it out the pulley from the base plate. You can check. I usually use the osteotomes to take it out. It's really easy, and you have to confirm these screw fixations and general fixation of the base plate. We have to use those. The size of the base plate was 28, not 25. So you have to consider about the size of base plate. The other things are really easy and smooth going. So I think it's not that difficult, but it's not that easy anyhow, but much better than conversion from the normal stemmed prosthesis. This 1 year of post-op, the patient is really happy. So how about the reverse? There are several papers from the Europe that's good outcomes in about 5 years follow-up, and also the 4 years follow-up, good outcome if the bone quality is good. And also, this is the longest follow-up from Europe. That's almost 9 years follow-up. Of revision is 17%, but it's not related to implant related. So probably good outcome, but we need further long-term follow-up. But as you know, that we have several patients of this kind of metal failure of the humeral tray. I don't know, this is due to the component of metal or some kind of biomechanics of the reverse of the nanostem, but it was retrieved in the market in the United States and Korea, but still in European countries, they use stainless stem for the reverse arthroplasty. We will see if further follow-ups from European countries. So I will show briefly about my tips of the anatomical TSA with the stainless stem. Several videos I will show you. So it's really easy. We don't have to prepare the humeral stem. So it's running or now? I think it's not running now. It's a video. No.
Yes.
Okay.
Running.
This video is running, right?
Yes.
So usually we don't have to have the rim into the medullary canal. I like to use this, measure the sizer and use some fixation of the sizer to the metaphysis with a guide pin. I like to use that component's guide pin as a reference. I like to use the extramedullary cutting block to make it the proper neck shaft angle. And the important thing is the size of the nanostem. To maximize the size is better in terms of stability of the nanostem. Step-by-step rimming of the proximal metaphysis, and then broaching, one time of broaching with the proper size. That's all. It's easy to to do the proximal humerus preparations, easy, simple. I usually palpate the cut surface of humeral neck cut, and if it is firm enough, I go through the nano humeral implant. But if it is really soft and really we can break by your finger, I like to change to a mini stem or micro stem for the proximal humeral. After the subscap repair, transosseous sutures, I irrigate the cut surface and nanostem, several taps, that's all, and measure the size and also insert the humeral head. That's all. It's easy, simple, and we can save a lot of times for that. I have several tips to good outcomes with the nanostem. Number one, we don't have any stem, so it's easy to be varus or valgus by your intention. So probably you better use the cutting block for the humeral neck cut. Even though I know you guys are really expert on that. And also, it can be easily retroverted or the anteverted by during your insertion. So the fellows and residents, careful inspection during the broaching or implantation, keep parallel that's cut surface, and broaching and implant will parallel to that. Okay? Sorry about some kind of the problems with my advancing of these slides. Also, the nanostem position size and position of the nanostem is important. The left side of the X-rays, I think the nanostem is a little bit inferior and violate the subcondylar cortical line. So during the preparation, maximize the size of nanostem is important. But you have to consider the inferior bone stuff, especially there's a patient of the inferior bony spurs around there. So I recommend you use the superior subcondylar cortical line to match the size. So I don't know why the slide is going automatically. I don't know. Sorry about that. So you'd better use subcondylar line. Subcondylar cortical line would be the good. I'm sorry about this. I don't know why. So please use the subcondylar cortical line for the reference of the nano size, not the inferior one. So in my conclusion that stemless humeral prosthesis is good in terms of achieving good anatomical reconstruction, and also we can reduce the intraoperative and postoperative humeral fractures. So probably it's really good, one of the bone-preserving arthroplasty for the late conversion or late revision of the anatomical TSA. Thank you very much.
Professor Rowe, that was outstanding. So much for sharing your tips. You have so much experience with that. We very much appreciate that. I have to say this was an absolutely wonderful webinar that we had today. Great tips and pearls from our faculty. And our faculty, very impressive. We got all the talks in just on time. But again, we very much appreciate it. I'd like to thank the team at Zimmer Biomet for being able to put this together. Been very informative and a great discussion. With that, Clarence and the team, I'll turn it over to you for any concluding remarks.
Anupam, do you want to say something, Anupam?
I was just unmuting myself, sorry, I was on mute. So thanks, Dr. Spelling, thanks for your kind words. And on behalf of Zimmer Biomet, I would like to thank you, Dr. DeQueen, Dr. Bancha, Professor Rowe, and Dr. Bancha. I think all the talks were great, and I'm sure will add a lot of value to all the surgeons who are attending from across Asia Pacific. And also, I would like to say that as Dr. Spelling mentioned, as part of Zimmer Biomet, we are launching innovative solutions like Alliance Renoid, Signature, and Planner. and we'll continue to invest in technologies, in emerging technologies in shoulder arthroplasty, and also in programs like these where we really want to stress on medical education. So Zimmer Biomet just doesn't want to be a company selling implants. We also want to improve shoulder arthroplasty practices across Asia Pacific. So thanks a lot from Zimmer Biomet side to all the faculties and all the audience also for taking out time for the webinar. Violent to you and Clarence.